Today's topic is peptic ulcer. It's variously called as acid peptic disease. It's also called as peptic ulcer disease. It's now commonly called as peptic ulcer. Lot has changed. Lot has changed in peptic ulcer since the time I used to take lectures 30, 40 years ago, and today. There's a vast difference in knowledge. So many things have changed. I have tried to amalgamate the old and new together to formulate a pattern of lecture which is coherent and makes some sense to you. I only wish, pray, and hope that I am successful in doing it. Peptic ulcer, by definition, is a disease which is produced by necrosis by acid and pepsin. Acid is more important than pepsin. Therefore, peptic ulcer is a common name, but here acid is missing. Acid peptic disease is such a vast name, it looks as if it involves the large organ. We commonly use peptic ulcer, we keep on using peptic ulcer. Peptic ulcers, as I said, is necrosis because of acid peptic digestion. Any mucosa which comes in contact with acid and pepsin can undergo peptic ulceration. There are two types, acute and chronic. Acute ulcers are possibly common, but few acute ulcers convert themselves into chronicity. And this is what we are going to talk about. Chronicity is produced by allowing not to heal an acute ulcer by acid peptic digestion. Sites of peptic ulcer are, the commonest is duodenum. The first part of duodenum, mostly, more than 85% or 90% of ulcers are situated in the duodenum, first part. Second is stomach. Third is lower end of esophagus. Fourth is gastrogenostoma stoma. Fifth is once in a while a gastric mucosa lining of mucus diverticulum. Incidence of disease. There is only one reference of United States where I could find a definite incidence of disease. They say 2% of their population suffers from duodenal ulcer. Nowhere else I found incidence. But they also say that last 40 years, there is decreasing incidence of duodenal ulcers even before the advent of H2 blockers and proton pump inhibitors. Gradually, the incidence is going down. The reason is not known. The hospital admissions, OPD attendance possibly continues to be high, but hospital admissions have gone down so tremendously, and therefore, even the operations done for duodenal ulcer have almost become indistinct. When we talk of etiology of duodenal ulcer, as I said, duodenal and gastric, both ulcers are important, but most bulk is duodenal. I'm going to talk of duodenal ulcer first and gastric ulcer separately. Etiology of a duodenal ulcer. There was a time when you used to talk about so many factors predisposing for duodenal ulcer, obviously because etiology was not known. Right from age, sex, geographical distribution, diet, hot spicy diet, alcohol, tobacco, smoking, racial, familial, all kinds of things. Today, the stress on discussing etiology has gone down. We have few predisposing factors which are known and which are accepted. Etiologically, there is this distinct familial predisposition, very mild but true. The age has shifted. Duodenal ulcer was said to be a disease of young age, 30 to 40. Now the age has shifted and has become a disease of 40 and 50s and 60s. Sex are distinctly more common in males than in females. But as the age is shifting, the sex difference is becoming less. We are now 2 to 3 males to 1 female. Duodenals are definitely predominant in males. Smoking. Smoking has relations. Smokers have a higher chance of getting duodenal ulcer than non-smokers. Alcoholics have a higher chance of getting duodenal ulcer than non-alcoholics. The new factor which has been added is aspirin and NSAIDs, non-steroidal anti-inflammatory agents. Because the age of a patient is increasing and these drugs are being commonly prescribed in this age, they have added as an important cause of etiology of duodenal ulcer. And the last but not the least is Helicobacter pylori, an organism, spiral-shaped organism, which is supposed to involve almost 50 to 80% of population. A peculiar organism which secretes urea and urea splits urea and secretes ammonia to turn this stomach medium into acidic, which leads to stimulation of gastric secreting cell, producing hyperchlorhydria. The hyperchlorhydria leads to atrophic gastritis. Atrophic gastritis leads to ulceration and many times malignancy also. Helicobacter pylori does not survive in duodenum because of alkaline medium. Why Helicobacter pylori gastritis produces duodenal ulcer is again unknown, but most probably the high acid secretion or high acid containing food which is transmitted to duodenum produces an intestinal metaplasia, and therefore Helicobacter pylori produces duodenal ulcer. Otherwise, individually has no capacity to go into the duodenum. Coming to pathology. The first part of duodenum, the two posterior wall, accounts for more than 85% of duodenal ulcers. Why do they select posterior wall? God alone knows. About 5% ulcers are situated on the anterior wall of duodenum. There are kissing ulcers also, anterior and posterior wall together. The ulcers have been described in second part of duodenum also. They are classical chronic benign ulcers, usually less than a centimeter in diameter or a few millimeters in diameter, covered by granular tissue, has sloping edge. There may be slough on its surface. This is the only benign ulcer known which is known to penetrate. This ulcer, without being malignant, has a capacity to involve the entire wall of duodenum. Chronicities leading to penetration into external organs like pancreas has become very, very unusual because chronicity itself has become unusual. The appearance is important. How it appears is important to know because in barium meal studies and duodenal gastroscopy, the person should be conversant with the appearance of a disease, then only he can diagnose a duodenal ulcer. Ultimately, it leads to distortion of duodenum, distortion of pylorus, congestion. The base of the ulcer surrounding it has endarteritis obliterans, therefore they don't bleed frequently. The penetrations of the pancreas have become rare. The symptomatology. The hospital attendance for duodenal ulcer has gone down. The incidence of surgery for duodenal ulcer, incidence of OPD attendance is there, but the hospital admissions have gone down tremendously. The operations also have gone down tremendously. Hospital admission, most of the patients present with dyspepsia. Dyspepsia is a syndrome complex or symptom complex related to upper abdomen, like vague abdominal pain, sense of distension after meals, slight nausea. Most of the patients present with dyspepsia, but classical features is number one, pain in the epigastrium. Pain is pricking, burning, situated in the epigastric region without radiation and is related to meals. The pain which disappears after taking food and reappears after 3 to 4 hours of digestion of food. Classical pain described nowadays, radiation to back is practically unknown because pancreatic penetrations do not occur. The pain which is relieved after this, a patient getting up classically at 2 a.m. or 3 a.m. in the night because of hunger and pain, and patient takes something and the pain disappears, is a very classical presentation of duodenal ulcer, but seen very rarely. Intermittent vomiting, weight loss, melena, or other symptoms which associate themselves with duodenal ulcer. Signs. This one disease is a disease of symptoms, not signs. There is only one sign described, and that sign is a tender spot just above and to the right of umbilicus. Today's OPD, patient says I have pain in the epigastrium. Nobody talks to him. Nobody takes a history. Straight the patient goes for ultrasound. Ultrasound shows nothing. Therefore, clinical diagnosis of duodenal ulcer has become very difficult unless patient has classical symptomatology, which is seen in about 40% of patients. Clinical diagnosis becomes difficult. Sometimes the diagnosis is labeled on basis of hazy symptoms which are not classical of duodenal ulcer. This brings us to investigations for diagnosis of duodenal ulcer. There were so many investigations in bygone days. Acid studies, barium studies, maximum acid output, basic acid output, stool focused blood, barium studies. All these tests have disappeared. Barium studies it was a shit anchoring diagnosis, had a diagnostic efficiency in an excellent radiologist's hands to the extent of 80%. They also have gone out of order. The one investigation which came to relieve a clinician for make a definite diagnosis is flexible gastroduodenoscopy, the shit anchoring diagnosis of duodenal ulcer, where a patient routinely comes in OPD with dyspepsia or goes to any practitioner. All dyspepsias are treated with modern drugs, H2 blockers and proton pump inhibitors. Dyspepsias disappear like this. Patients don't come back. Therefore, gastroscopies or duodenoscopies are not done. This is a common story everywhere. When a patient comes to you with recurrent relapses very fast, it stops treatment. After a few months, he again gets it. If this happens repeatedly, patient above the age of 45, patient who has bleeding, either a visible melena or hematomasis, patient who loses weight, patients where the symptoms continue in spite of treatment are the indications for gastroscopy. Is a must. Such patients must undergo gastroduodenoscopy. Shows a classical ulcer in more than 90%, more than 95% cases. Sometimes the ulcer is not seen, but the signs or evidence of an ulcer is seen prior to pyloric spasm, congestion, deformity of pylorus, and this has become a sheet anchor in the diagnosis of peptic ulcer. When I say at the end of all this, after having discussed etiology and pathology, clinical presentation and investigation, why do we keep on saying the etiology is not known? Etiology is not known because it is said that the duodenal ulcer, both the ulcers are, especially duodenal ulcers, a disease caused by hyperacidity. There is basic acid output increases, maximum acid output increases. There is a massive increase in apparent cell mass. God only knows why. With all this, there may be intestinal metaplasia, Helicobacter pylori, whatever you say. But what it does not explain is why less than a centimeter area of duodenum is involved. Whether it is acidity or is it a failure of local defense mechanism, whether it's secretion of drop in the defensing or secretion of toxins by Helicobacter pylori. Why only a centimeter area of duodenum? That is still not explained. And therefore, we keep on saying the etiology is not known. We know we high risk factors, but exactly who is going to suffer is not known. Fortunately, duodenal ulcers do not undergo malignant change. Malignancy is practically unknown. Therefore, we put down indications for gastroscopy. Those patients, I have already enumerated the indications where a gastroscopy is essential to make a diagnosis. Management. Before I go to management, complications. There is a large group of patients called as intractable disease, where in spite of non-specific medical treatment, the ulcer did not heal and patient kept up to be symptomatic. Today, with the advent of powerful anti-acid drugs, this intractability has disappeared. Only three complications which are known, which need cognizance, is bleeding, second is perforation, and third is stenosis. In that order, bleeding first, next perforation, and pylori stenosis. Bleeding can occur, we are going to talk about complications much later, but these three complications need to be detailed a bit before we continue to talk on peptic ulcer. Management of peptic ulcer is divided into medical and surgical. Medical management consists of moderation in habits. Whatever was responsible in etiology, like smoking, alcoholism, hot spicy food, aspirins, NSAIDs, moderation and rationalization of the habits of patient. The mainstay in management is H2 blockers and proton pump inhibitors. H2 blockers leads to reduction of acidity massively, but proton pump inhibitors even more competent to reduce acidity, and long-term proton pump inhibitors can almost make a patient ochlorhydric. The drugs are given for a period of 3 to 6 weeks. The symptoms just disappear within 3-4 days. Symptomatic relief is very fast. Gastroscopies are not done. Therefore, and when the patient feels all right, the relief of symptom is there, he either stops the treatment or stops coming to the hospital. Therefore, to find out an exact incidence of duodenal ulcer in the population has become very, very difficult unless the gastroscopist decides the number of scopies done by him, how many turned out to be duodenal ulcer. I have talked to a few scopists in Nagpur. They say most of the scopies are done for gastritis and non-specific non-specific dyspepsias which have nothing in the stomach. Once in a while, they detect a duodenal ulcer. Medical therapy, when repeatedly a patient comes, the results are so fantastic that the surgical treatment has gone down practically into oblivion. But once in a while, they are needed in emergency. Therefore, how surgical treatment developed is essential to know. Today, years and years have passed where people have not done elective surgery for peptic ulcer. Indications for surgery today is only complication. Intractability has disappeared as a cause. Therefore, elective surgery of duodenal ulcer has also disappeared. The birth of surgery in duodenal ulcer came when a patient with peptic ulcer having a mass in the abdomen, very thinned out, dehydrated, was diagnosed as malignancy and was kept for gastrectomy. Patient's condition deteriorated. Anesthetist warned the surgeon. He just did a gastrojejunostomy because he had a patient had a pyloric obstruction and he came out without resecting the mass in the stomach. Patient improved. This proved that bypassing the entrum, the ulcer healed. First gastrojejunostomy came into existence in 1943, where people realized all these operations based on basically two principles. Number one, bypass the entrum, stop the direct stimulation of gastric secreting cells, and second is acid reducing factors. Most important was vagotomy, and second was remove the part of a stomach which contains gastric cells. This is the basic of surgery. The first surgery came into existence was gastrojejunostomy. It led to bypass of gas entry, led to reduction of acidity, and ulcers healed. But the basic diathesis of maximum acid output, basic diathesis of increased parietal cell persisted. It was only a matter of time that recurrence would occur, and recurrence did occur. It had a very small mortality, but the recurrence rate was very high as to extent of 30 to 40%. At that time, the operations were done at a much younger age group. Second operation which came to existence was vagotomy, called as truncal vagotomy, described by Draxted somewhere in 1946-48. Truncal vagotomy alone, without a drainage procedure, led to stasis in the stomach. It did lead to healing of an ulcer, but stasis in the stomach led to recurrence. Not only of duodenal ulcer, but addition of gastric ulcer also present. Very fast they realized that vagotomy alone cannot be a treatment. They added pyloroplasty, a drainage procedure, to stop the stasis in the stomach. The classical operation was pyloroplasty, and second was gastrojejunostomy. In a patient with a chronic duodenal ulcer, where duodenum is distorted and contracted, pyloroplasty becomes a little difficult operation, though it's better than gastrojejunostomy. But gastrojejunostomy became more popular, and vagotomy, truncal vagotomy, and associated with gastrojejunostomy become very standard, commonly performed operations for duodenal ulcer with a very good results. But here also, there was not only a slight mortality, but morbidity also. To improve on it came various forms of vagotomy, because vagotomy produced important side symptom of post-vagotomy diarrhea. They did a selective vagotomy. Selective vagotomy was avoid celiac branch and hepatic branch and cut it below the vagus. And add gastrojejunostomy. It had no effect on the complications of vagotomy, truncal vagotomy with gastrostomy, or selective vagotomy and gastrostomy. Then came highly selective. Highly selective vagotomy needed an expertise. It amounted to cutting of nerves of lateral jet in the lesser curvature of stomach. Each one of them, which was going into the lesser curvature, except the last one, crowfoot, which supplies the antrum and pylorus, that was left out. The basis was very sound, that this vagotomy to the body or stomach would cut down the acidity and safeguarding the crowfoot will not disturb the emptying of stomach. Highly selective vagotomy became a successful operation with minimum complications, but recurrences were there. The last operation which came into existence was antrectomy. As a matter, it came before highly selective vagotomy, antrectomy and vagotomy, where the antrum was removed and vagotomy was added. As far as reduction of acidity was concerned, this was the best operation. But because stomach is removed, it had a mortality and it has the disadvantages of removal part of stomach. Therefore, by the time antrectomy could be evaluated for a long time, the specific drugs came, specific treatment came. Therefore, long evaluation, people stopped doing antrectomy. Gastrectomy was the first original operation to reduce the acidity, but gastrectomy long ago has been removed as an operation for peptic ulcer. Today, these operations are hardly ever done even for complications. They are mentioned because you should know how surgery progressed in duodenal ulcer, how gradually duodenal ulcer treatment has walked in the hands of scopists and medical gastroenterologists and not surgeons. The complications of surgical operation, surgery of duodenal ulcer, number one was dumping syndrome, early and late, distension of abdomen, biliary vomiting, the residual stomach getting an ulceration, stomal ulcers in wherever gastrojejunostomy was done. The mortality varied from 0.1 to 2.5 to 3% whenever gastrectomy was done. There was no operation, not a single operation, which did not have mortality or morbidity. That was the reason, and it is quite understood. If a etiology of a disease is not known, no operation can ever be successful. You keep on searching for an ideal operation, and the ideal operation never comes. The only example I gave last time was Ramsted's operation, where etiology of a disease was not known. Even then, the operation was 100% successful. So, such is the story of duodenal ulcer. Duodenal ulcer surgical practice is becoming lesser and less important. I hope I have conveyed the recent advances with photos.